Okay, I'm going to get started. Dr. Holcomb, I'm the second-year pediatric neuropsychology fellow at Dartmouth Hitchcock Medical Center. And I have, over the years of my training, been in several different environments where I've done an extensive amount of neuropsych evaluations of working with children with epilepsy. I worked at the University of Western Ontario's Medical Center in their inpatient epilepsy unit for a year, and at Sick Kids in Toronto for about 6 months, specifically with epilepsy. And then in the context of my fellowship at Dartmouth, work and see children on an outpatient basis for neuropsych evaluations with epilepsy. So I was asked to give this presentation today, and there were kind of two thoughts that were running through my mind in sort of how to go about approaching this presentation and how to make it most worthwhile to all of you. The first thought that I had is that my background is actually as a school psychologist. My PhD is in school psychology, so I have worked on the school side of things and worked in school districts and seen what it's like to be in IEP meetings and the frustration that comes from that standpoint. So I want this conversation to be very practical because it's a neuropsych evaluation for children with epilepsy is not just a document that gets ended up using in the medical context, but it ends up being used in the academic context too. So please feel free to interrupt me while I'm giving a talk and ask any questions, and I always try to very much be brief so that I can leave some time at the end for questions as well. So I'd really like it to be practical. The second thing is that, and I told this story last week, so at a different conference I was at, so if you're listening to it for the second time, I apologize, but I had a mother a couple of months ago who drove from Maine, and the reason I mentioned that she's from Maine is that I have a transplant to New Hampshire, and it takes me 25 minutes to get to a grocery store from where I live. So I've become very jaded about how far people have to drive for things because I have to drive a long distance too. But when I saw that this mother was from Maine, I got curious and I Google mapped it and saw it was about a 5.5 hour drive that she came for an appointment with me. And when I went out to the waiting room to pick her up and her son up, she was very hostile towards me. She was not happy to be there. And as I started talking to her and kind of getting to understand why that she was there, I quickly realized she didn't know why she was there. And she was doing this because she cared about her son. She was told to come to this medical appointment, and she drove 5.5 hours not knowing why she was there, not realizing what a neuropsych evaluation was, not knowing it was going to be all day, things like that. And so I wanted to sort of also with this talk take a step back and just sort of explain what neuropsychology is, what we're trying to accomplish in the context of epilepsy, and why it's important and why you may be involved with us if you have a child with epilepsy from the time of diagnosis to their adulthood, because it is something that we become readily involved in and I think add a lot to the picture. But the only other thing that I would add before I get into the talk is that I mentioned this again in my talk last week. In pediatrics, there are a lot of people in your child's life who do assessments. There are people OT and PT in school, and lots of people doing lots of assessments. Under almost all circumstances, I say that they do a great job and that you can just stick with their assessments and then not everybody needs a neuropsych. For epilepsy, I changed my opinion on that. Kids really do need a neuropsych if they have epilepsy. It's very important that just the depth that we go to that other assessments don't go to is just really important in making sure that you understand where the deficits are. Schools do a great job with assessments and they can do a great job at educational programming, but to really, really understand where these deficits can be occurring for kids with epilepsy, it really is important to have a full neuropsych evaluation. So that's my plug, and hopefully by the end of the talk you'll understand why I'm saying this. So I've kind of gone over the slide already, but this is kind of the goals of my talk. I want to talk about what is neuropsychology, what the neuropsych assessment is, what it covers, why it's important in epilepsy, and then I'll give you a quick case example. So neuropsychology is a field that's concerned with the understanding of the relationships between the human brain and behavior. And it's applying that understanding through basically assessment. So I'm probably sure that most of you are aware that the one thing that people do know about neuropsych is that we give lots and lots of tests. And these are tests that are designed to look at how the brain is functioning, how different aspects of the brain is functioning. And if you actually go back into the sort of the origins of epilepsy and neuropsychology before the invent of fMRI and MRI, we were the people that were called in to try to help localize. Thank goodness we don't do that now. Okay, we're somewhat good at localization. We can usually go left or right, but beyond that, we're not able to localize that much more specifically. So it's still an important part of epilepsy treatment, but our role has sort of shifted over the last 15 to 20 years, in that we're now more interested in trying to track these deficits and trying to intervene. And I always like to talk about this guy. Anybody know who this guy is? The picture there? Okay. So I could go way back and argue that neuropsychology started in antiquities with Homer and Plato or whatnot. I think modern neuropsychology started with this guy, and I think it's appropriate because he's a New Hampshire native. This is Phineas Gage. Phineas Gage was a railroad worker who, when he was tamping down, he was using a large metal pipe. He was tamping down explosives to lay some railroad track. He inadvertently set off the explosion, and the metal rod went up through his eye socket and out the top of his head. And he survived, okay? And you can actually go to one of the Smithsonian's down in Washington, D.C. and actually see his skull now, and the metal rod. But what happened was... I am full of interesting facts, so... basically, by a universal opinion, before this accident, Phineas was known as a very affable man, very friendly, loved being around kids, was kind to animals, and after the event was a complete jerk. He couldn't hold down a job. He drifted from place to place to place. He was in a circus in Chile for a while because that's the only paying work he could get. A completely different man after this accident happened. And I like to think that this is kind of where modern day medicine sort of became interested in the effects of insult on the brain and how it changes personality, how it changes cognitive abilities. And from there, we get people like David Wechsler, who designed the whisk, who, if you have children, you're very probably familiar with because it gets talked about all the time in the schools. The history of neuropsychology is very, very prevalent in this area. That Boston Children's and a woman by the name of Edith Kaplan, very prevalent in sort of developing many of the tests that we still use to this day, and really also developing this idea that for children especially, and again, I hope that this is illustrated in my example, you can't just stop at the numbers, and that the numbers don't define a child. And Edith came up with this idea of the process approach of it's also just as important to understand how we got to the numbers and how the child performed on the task and whether or not there's some information there that's worth looking at as well. And so, that's kind of my grounding. It's important to note that for neuropsychologists that we are first and foremost psychologists as well, and we'll talk about the evaluation next, but that's where I come at my perspective from things. I come at it from the psychology perspective rather than the MD medical doctor perspective. One of the other things that I think is important to point out about a neuropsych evaluation is that when I see a patient, it is my only patient for the day. So it's usually an 8-hour evaluation, and I don't have more than one that I see in a day. It puts me in a unique perspective to actually be able to spend time with parents, spend time with family, spend time with the kid, and get to know them a little bit better than your 15-minute visit that you might have with your general care practitioner. And that's not to say anything bad about the way that the rest of medicine works. It's just that I'm in a unique perspective to be able to spend a lot of time. So my evaluation is the place to show up with the great big binders of all the paperwork that you've collected over the years with all the different IEPs and, flu shots and everything like that. I'm interested in that, and I want to have the time to look through it. I devote I devote a good deal of time to doing an interview and talking through things with parents and trying to understand why they're there, what are the problems that we're facing, what it is that we're hoping to get out of this evaluation. And as I said last week, I'm more than willing for parents to come with an agenda. Okay? If you think that your child should be getting something at school, let me know, okay? Because, and let any neuropsychologist know. Because one, we can address the issue as whether or not it's an appropriate issue for us to be addressing. So yes, I can help you with that, or no, I can't. But here's who might be able to help with that. But then second, if I know, then I can look in the data and try to find a way to rationalize that and help you. My default is always to believe parents. It's always to say, okay, this is what you're seeing. It may or may not show up on our test, but how can I explain why it has or hasn't shown up on our test? Okay. So, on neuropsych evaluation, first of all, as I mentioned, it's a long process. Okay. Bring something. If you have your child going through this, bring something to read. Bring an iPad. Steal your son or daughter's iPad to use yourself. It takes a long time. It usually involves at least an hour interview where we're going to go through all the developmental stuff. When did they learn to walk, talk? How was the pregnancy? All that sort of stuff. So be prepared to talk about that. Also be prepared, sometimes parents come in and there are certain things that they don't want to talk about in front of their child. So kind of letting people know up front so that we can, work around that so that you can get all of the information that's necessary. But it's a long interview, like I said, usually about an hour. And we're looking at medical history, looking at developmental history, looking at academic history, because all of those things help us put into context the testing results and make more sense of them. It's also, like I said, a psychological evaluation. So we look and we at least screen for things like mood, okay, which is a big thing in epilepsy, especially as kids start to get older. I find on a very regular basis that especially older children with epilepsy, they don't feel like they're the same as their peers, and they're not, because they've gone through a very traumatic and long-standing illness, and so the concerns that they have at 14 are not the same concerns that other 14-year-olds have, and they have a hard time relating to peers, and so you see a lot of mood issues and anxiety, depression. It's important to be able to talk about that. It's important to prepare your child before they come to the evaluation to be prepared to talk about that a little bit, okay? Because it's something that we're interested in. Also interested in looking at behavior, whether it's poor at school or it's great at school, and whether it's bad at home and great at school, or if we're seeing differences, that type of stuff. And then personality, and we'll talk about this in a second, but different types of epilepsy, because of their location, because of the frequency, can have a dramatic effect and can change personality over time. And that's an important thing to be able to discuss and be able to talk about, because it can cause a lot of problems within the family unit. And especially as children with epilepsy get older, I start to see my role shift a lot more in that I start caring less and less about what the numbers are saying, especially if the child's had epilepsy for a long period of time, because we're starting to see more stable patterns of their cognitive abilities, and more about what those patterns are now meaning on the social and the family dynamic. A lot of these kids, if they can't move out of the home and they're still in the parents' basement and whatnot, what that's doing to the relationship between parent and child, and how that's affecting everything, and trying to intervene as much as possible in that side of things. So my role very much shifts side field developmentally and by kids' age, and so personality is a big one. And then of course, assessment of cognitive abilities. So, okay. So with a neuropsych evaluation, the primary focus is on cognitive abilities, and there's a lot of things that kind of underlie cognitive abilities. So there is general intellectual ability, which is the WISC, especially if they're under the age of 16. So many of you are probably familiar with this. It's what they do in the schools. And I view the WISC as a way of showing level of abilities, okay? So it's kind of the place that we start with to say, if skills are here on the WISC, then we have certain expectations of where skills should be for other areas. And then in epilepsy, we do take it a little bit further in that there are certain types of epilepsy that develop certain patterns within general cognitive abilities. And so we start to see splits between sort of the left side of the brain and the right side of the brain, so verbal abilities and perceptual reasoning abilities. And I think the example I have is kind of a good, clear example of how that can show up and sort of highlighting where the strengths and the weaknesses may be developing. And did you have a question?
Would you define the WISC? I'm not familiar.
Okay, yes, so the WISC, it stands for the Wechsler Intelligence Scale for Children. It's a series of 10 tests. And I'll show you, I have an example where I actually show you what the numbers look like. But a lot of times the interaction that people have with the WISC is that it boils down into one number, a child's intellect, okay? And a lot of people like to take that one number and run with it, and they don't understand the nuances of it. And that's why there can be some kind of negative feelings towards the WISC in people's interactions with it, because they take this one number and they try to make it mean more than it really does. Okay?
And schools use this?
Schools use it, yep. It's pretty much the gold standard of IQ assessment. It certainly is in New Hampshire. So if you ever have a child have a school-based evaluation, the WISC will be what's used. So, yeah. So, yeah.
I'm just curious to know what other evaluation techniques you might have for kids that are much more lower functioning, or WISC would be.
Yeah. So, from a general IQ perspective, when kids are lower functioning, we have a measure called the DOS, which is the Developmental Ability Scale test. It's got better floors, if you will, for lower functioning children. Beyond that, there aren't a whole lot of really good tests when they're really, really low functioning for us to be able to get a good sense. When kids are younger, there's some developmental scales like the Mullen and the Bailey, which are really designed around more early developmental motor and language skills, and so we can sort of get a developmental age using those tasks. But to really get a nuanced IQ, when they're lower functioning, it becomes a lot more difficult.
You don't use a Cali or Zumba?
We don't. No. Any questions about that? So IQ is one of the big areas, and it is also important because IQ in epilepsy patients, there is a difference in them compared to normal populations. So we see the difference as time progresses. At time of diagnosis, they're just like normal children. But after a few years, it tends to be that there's about a 15-point difference in IQ for most children. So they tend to fall into more of the low average range of IQ, which again, when you know that about level and you have expectations, that changes the way that you're viewing things like academics and academic planning and what should be expected of them in school and the pace that they should be going at curriculum-wise and whatnot. Okay. So IQ is the first one. The second kind of big area that we become very much involved in is with language, and there's a couple of reasons for that. One is that from a simple standpoint that we live in a very verbally moderated world, right? If you don't have language skills, it's really, really difficult to kind of make your way in the world independently. So we're very involved with assessment of language skills. And then two, because the highest percentage of pediatric epilepsies is left temporal lobe epilepsy, and for most people, the left temporal lobe is where language is housed at. It tends to be one of the skill areas that gets most often impacted. So we test language skills everywhere, all the way from basic letter identification to passage comprehension and reading rates, trying to really see where language is kind of, where children are having trouble with language. And what they're finding more and more, at least with the research for left temporal lobe epilepsy, not for all epilepsies, but for left temporal lobe epilepsy, it has to do with an organizational component of language. So I don't know if any of you have ever played I think the game is Taboo, where you have like the key word, but you're not allowed to say the specific things and you try to cue somebody in, Taboo. That's kind of an example of what will happen when children have left temporal lobe epilepsy, in that they lack, it's not that they don't have the vocabulary, they lack the organizational structure to use vocabulary appropriately. So if you confront them, for example, with a picture of a cat, They can't come up with the word cat. They can say, oh, that's an animal, and I have one at home, and it purrs. But being forced to come up with a single word can be very difficult. I sometimes call it tip of the tongue phenomena. And that happens more often with children with epilepsy. And then you see the same sort of process happen in sort of their fluent ability to use language. So how quickly they can just come up with words. So you can do a lot of things when you see those problems emerging and sort of teaching kids almost to be stoic and taking their time with their language, thinking through what they're going to say before they say it, slowing down, because that's kind of where we see some of the language problems start to occur, at least in left temporal epilepsy. So language is incredibly important. Language is also incredibly important because it's a huge factor in when they make the decision about whether to do resective surgery or not. So they're always one of their first and foremost concerns when they decide whether or not somebody is a good candidate for doing a resective surgery is whether or not you're likely to damage language areas. And then there's some other tests that neuropsych is involved with. You may be familiar with the WADA. That may be something that, in the progress of your child's epilepsy that may come up. That's a test where we actually go in and we put half the brain to sleep and we test and make sure we can see where language actually is. And we put the other half of the brain to sleep to see if language is represented on both sides of the brain. So it's incredibly important. And the last thing I'll say about language is that the brain itself recognizes that it's important. So what we see often is if children have epilepsy that starts at a very, very young age, and it is, for example, in the left temporal lobe, the brain will actually make the decision to move language skills to the right side, to the undamaged side, and will reorganize itself. And that will actually then cause it to sort of crowd out other skills that are typically associated with the right-hand side of the brain. So you can see a lot of interesting things happen with language, so very concerned about language. Do a lot of testing to try to really understand where the skills deficits may be in language. Similarly, the same thing with memory. So memory, at least verbal memory, is typically thought of to be housed in the left-hand side of the brain. So do a lot of assessments with memory, looking at seeing where verbal memory is and where the deficits may be with memory. And what we find, especially again, and I'm sorry I keep going back to left temporal lobe epilepsy, but it's kind of the one that we know the most about. What we find is, again, it becomes an organizational aspect when it comes to memory. So when you test a child's memory and they have left temporal lobe epilepsy, that you can see that they clearly have gotten the information in, but it's very difficult for them to get the information out. So when you ask them, when you read a long list of words to them, for example, and you ask them, what do you recall? They have a really hard time doing that because they have to kind of organize it all and get it out. But then if you just read a bunch of words to them and say, did you hear this one on the list or did you not hear this one on the list? So they don't actually have to get it out, they just have to recognize it. They do phenomenally well on that. So from our perspective, that says that the information got in, but it's very difficult for them to get it out. So there's a lot of stuff that's going on in the rehabilitation side of it to try to help with memory cueing and to try to find other paths of accessing that memory and give them sort of touchstones, if you will, so that they they can access it better and use it more effectively. Attention and executive function, that's probably the last area that I'll talk about that we assess very specifically. That has a lot to do with the fact that children with epilepsy have really, really high comorbidity rates with ADHD. So it's always important for us to kind of test what their attentional capacity is. And that also, again, plays into this idea of organization, because if you're not paying attention and you're not getting all the information, it's very hard to organize it appropriately and to do something with it. So, yeah.
I lost what you. I didn't understand what you said. If you have epilepsy, it's a higher risk for getting ADHD, or
so the
morbidity to me is death.
Yeah, sorry. So the co-occurrence. So having epilepsy puts you at a greater likelihood of also having ADHD.
Okay, ADHD.
Yeah. And there's several. I mean, there's a lot of actual childhood learning disabilities are another one that you're at higher risk for having if you have epilepsy. Yeah.
If the ADHD is really symptomatic-based diagnosis, so is it a comorbidity or is it the processing issues from the epilepsy that show symptoms that in somebody who didn't have epilepsy would be called ADHD?
Yeah, and that's always a tough one to answer. It's it's sort of a chicken or the egg type argument about whether or not there was maybe prior to the epilepsy emerging, whether or not there was an attention deficit problem beforehand, or if it was caused by the epilepsy. It's usually pretty difficult for us to tell because we don't usually have testing from before. But regardless, it's there. The other thing that it's important for recognizing, and when I get into the case example, I'll point that out as well, is that children who have ADHD, when you look at their IQs, they're much lower in what I would call the efficiency area of IQ. Okay, so it ends up being, for kids with epilepsy, it ends up becoming a similar phenomenon to what you actually see with children with pediatric leukemia, where because they're less efficient at gaining new knowledge and gaining new information, they have this drop-off in skill acquisition. So it's not that they're losing information, it's not that they're not learning, but they do not learn at the same rate that their peers do. So being able to kind of point that out again from a practical standpoint to schools and educational planning and saying, they do learn, but you've got to go at a much slower pace. You've got to chunk things much more evenly for them, and they can't, overwhelm them with a ton of information at one point. So that's the other thing that's probably important to notice with the attention, is that they tend to be less efficient in their learning processes. So I hope I've given you some idea of why we're important for epilepsy, but if I haven't, I'll be a little bit more succinct now. Neuropsychology gets involved in epilepsy for a number of reasons, and it really does have to do a lot with the cognitive abnormalities that we see in pediatric epilepsy. So different types of seizures, different types of epilepsy have different cognitive profiles, can look different in different children. Seizure control plays a huge role in whether or not we're seeing cognitive declines or cognitive changes, deficits. Anti-epileptic medications, they do a really good job of trying to stay away from the ones that we know have specific patterns or deficits, but sometimes those are the medications that kids get put on, and so it's important to sort of be able to track that and to look and see if we're seeing those deficits, and then to, again, sometimes track them over time. It's also important because there are some children who, for whatever reason, the medications stop working at a point, and that usually comes with a cognitive change as well, so being able to look at how things are changing over time with regards to medication. And then there is some and more emerging research that based on sort of what the EEG looks like, that it can be predictive of certain cognitive profiles and the way that it can affect learning and whatnot. So those are some of the reasons that we're involved with epilepsy. And then also because cognition in and of itself can be changed in numerous types of ways with epilepsy. So you can actually have an abject loss or a decline in skills that were previously there. Okay, fortunately that doesn't happen all that often, but it can. Okay, as I mentioned, similar to kids with ALL, you can have this slowed rate of acquisition of abilities, which is important to understand and know. You can get sort of fixed deficits that don't seem to change no matter what you do. And that kind of goes along with sort of the high comorbidities of the high prevalencies of other types of disorders that show up in children with epilepsy. And then the other one that is becoming more and more apparent to me as a clinician, and I'm starting to get more and more involved with trying to make recommendations around, is the deficits that come around after a child's had a seizure and how the seizure has affected them. So, and this becomes sort of, again, where I put more of my psychology cap on. So the classic one I would like to that I'd like to illustrate that is I had a kid a couple of weeks ago who she had a tremendous fatigue after she'd had an epileptic episode. Okay, she also was being bullied at school because she was different. Okay, and she'd had several seizures at school, and that made her different. And kids are mean. So she developed this sort of avoidant behavior about going to school, and she used the fatigue to excessively get out of school. And she missed something like 45 days of school. And mom, readily so, was concerned about her daughter, didn't want her going to school if she was really fatigued. But there's sort of that interplay of the family dynamics of what was actually going on medically, and then some of the stuff going on for the daughter at school that needed to be addressed. Okay, and so again, it became less about the numbers to me and more about how do we address this? How do we get you back into school more often? What can we put into place to allow things to go a little bit better for you? And that had really nothing to do with the cognitive testing and the numbers that we had. But I was the person that kind of first got a chance to take a crack at it and to try to do something about it. So, a real quick case study. This is Jane. Jane's a 12-year-old female. She was diagnosed with complex partial seizures when she was 6 or 7. She also has a diagnosis of ADHD. I'll show you the numbers in a second, but she was seen by us for a reevaluation, so it was her 3rd full neuropsych evaluation. And she was seen by us this 3rd time because the school was reporting pretty dramatic decreases in functioning, declines in functioning, and the parents were reporting pretty significant declines in functioning, in working memory, being much more difficult to handle at home, a lot more behavioral outbursts. She had to repeat grades in school, and she had at this point an IEP in place. And I just kind of liked this quote. This is actually from one of her teachers. I won't read it out loud, but I'll let you guys read it. But again, teacher and individual teacher kind of seeing the same thing. And if I remember correctly, she was actually at a very small school in New Hampshire, so this teacher had actually had a long time interaction with her over several years and was able to really comment on the fact that, yeah, we really are seeing some declines here. So, and again, I'm sorry, I had no idea that I was going to have a screen up high. So if I can try to explain this to you. One of the things that I will mention right now about a neuropsych evaluation, please don't get bogged down in the numbers, okay? They confused me after doing this for 12 years. So every test has its own sort of scale that it's measured on. Every test has its own cutoffs of what is and isn't a good score. So if you get bogged down in the numbers, you'll kind of lose yourself and lose the point of the evaluation. So I try to point out a couple of the big ones so that you can at least follow those tests, but some of the smaller tests, just kind of read the explanation, and that will be a lot more helpful than getting bogged down in the numbers. So this is an example of what you might see for the WISC, as I was talking about earlier. Okay, so this is a general intelligence profile, and this column here is from 2009, 2010, and 2013. So you can see the 3 over time. And what's important is to look in the SS column. Okay, and the way that the WISC works is it's based off of a scale where 100 points is the exact middle. So 50% of kids get above 100 points, 50% of kids get below 100 points. Okay, and anything between 90 and 100, 80 to 110, somewhere in that range, we're pretty happy with that functioning. Okay, that we call that the average range, and about 75% of kids fall in that range. Okay, so it's not until scores start to fall below that we start to consider them deficits. So the first thing that I would point out is if you, well, let me stop back up for a second. The one thing that you don't see here is, and if you're familiar with looking at WISCs, you don't see the full scale IQ, okay? I purposely left that out, okay? And that again goes back to my stance that for these full scale IQs, people get too caught up on what that number is, and it doesn't mean anything. And especially when you start looking at this 2013 evaluation with the spread in the numbers, that full scale number is basically worthless. So at least in my reports, I don't report it if it's not meaningful, because I don't want people to spend too much time thinking about it. Okay? But that full scale number is based off of these 4 different composite indexes. So the first one, the verbal comprehension index, that's stuff that we've already previously learned. So it's things like vocabulary. It's how you verbally problem solve. It tends to be the type of stuff that's most resistant to any sort of brain insult too. Okay, so if you've had a traumatic brain injury, in Alzheimer's, things like that, it's kind of the last area to go. Okay, so once you've learned what a cat is, you kind of hold on to what a cat is. It's hard for you to lose that knowledge. Okay, and that's interesting because when you look at sort of the scores, you go from 81 to 89. And then in 2013, we see this drop to a 71. So 18-point decline, okay? That's a significant decline, okay? And she goes from being a low average to being in the borderline for verbal abilities. And I'll show you in the next slide, we can break down these verbal abilities even further and see where the deficits are coming from. But we are seeing this decline in verbal abilities, okay? The second line is perceptual reasoning, and that's kind of new and novel problem solving. So can you put some blocks together to form a puzzle? Can you look at a puzzle that's missing a piece and figure out which piece best goes there? And that tends to be more the right side of the brain as well. And as you see, she's kind of chugging along with those. They're all kind of in the 90s. There's not a big difference between them. And it's important to note that across these time spans, she's not only being compared against herself, so how does her performance compare relative to her past performances, but she's also being compared to other children her age. So that 96 in 2013 is against children that are that age, as opposed to the previous one, which is against children that age. So it's a clear growth of skills as well. Okay? And then the bottom 2 are the ones that I call kind of the efficiency part of IQ, and that's working memory. And my classic example of that is always, if I told you what my phone number was, could you hold on to it long enough to turn to the phone and dial it? So it's little chunks of information held for some period of time, and then you do something with it. Okay? And that's a tremendously important skill to have if, for example, you're sitting in a classroom with a teacher and she's lecturing or he's lecturing and you're trying to write and go back down to your notes and keep track of what's being said, not lose your place. You can see how if you can't do that, you would quickly get lost and not be able to keep track of what's going on. Okay? And then the last line is processing speed, and that's simple tasks that are done quickly. Okay? And again, these 2 bottom ones have more to do with efficiency than they have to do with sort of how smart you are. But what's interesting is that when kids are in their early teens, the bottom 2 lines are actually more predictive of IQ outcome and whether or not they'll be successful in college than the top 2 lines are. Okay? Because, and it makes sense if you think about what happens in curriculum in that 4th, 5th, 6th grade year. We move away from teaching the basic skills of reading, teaching the basic skills of math, to now what can you do with reading? Let's read books, let's comprehend them, let's make inferences and whatnot. So if you can't do the basic skills quickly and efficiently, you're going to see a drop-off in sort of your ability to maintain with your peers. Okay, so for this profile, again, we see this decline from the 89 to the 71 in verbal comprehension. So she's losing essentially things that we would think that she wouldn't lose. Okay, so knowledge that should be pretty crystallized and sort of stuck in her brain. And she's losing working memory. And you can see there's a 20-point drop in the working memory. Okay, so the first thing that kind of stands out to me in this is that we shouldn't see that top line going the way that it's going. Okay, that shouldn't be occurring. We shouldn't be actually losing crystallized information. So this is, and again, I'm sorry the slide's so busy, but this is a breakdown of all the tasks that are underneath those 4 lines. So the top 3 are the verbal abilities, the middle 3 are the perceptual, the 2 are the working memory, and the 2 are the processing speed. So if we look just at the one that says comprehension, I'm sorry I don't have the scores from 2009, but if you just start with the raw score, okay, so that's when they were doing the test and they're given points, how many points they actually scored. We go from 19 in 2010 to 13. So she actually got fewer points after 3 years, okay? And comprehension is a task where you're asked, what do you do if you see smoke coming from your neighbor's house, okay? It's sort of explaining complex social situations. Why do we apologize to people? That sort of stuff. So she's lost an ability to explain herself, okay? And when you actually look at the quality of the answers, what's interesting is that you could see in her answer sort of the idea was there and that she knew why you were supposed to apologize, but she couldn't organize the information in such a way that she could get credit for it, okay? So there was this flavor of her knowing what comprehension or what these different social situations were, but she couldn't organize it into a coherent fashion, okay? And that's important because I'll show you some other things that we looked at with language skills in a second, and it really does in this case come down to an organizational aspect, and that she was sort of losing the ability to sort of keep track of where she was in explaining herself, where she was in verbal processes, okay? And then the other one that I would point out in the top 3 lines is vocabulary. So again, in 2010, she got a raw score of 18. In 2013, she got a raw score of 24. So she is learning, okay? She's learning new vocabulary skills, but when you compare her in the second column, the 5 versus the 5, relative to her peers, she's not making any gains, okay? So she's staying at a very sort of flat knowledge acquisition level, if you will, okay? Take a sip here of water real quick. And then the last thing I would point out with this one is this letter number here. So this is a working memory task. It's all about organization. So you have to be able to sequence and you have to move things around in mind. Okay? And again, we see this drop off of raw score from 14 to 11. So her actual abilities of being able to organize and manipulate information in mind, we're seeing a decline in that. So from there, we did some other further testing to try to understand and better encapsulate where these deficits were. So we gave her a test of what's called comprehension of instructions. So it's literally a test that you could probably do with your kids at home, where you start with a very simple instruction, touch the blue dot, and then you get progressively more complex. And she did very poorly on this task. And what you'd see was a very, very quick drop-off, not only when you added extra layers to the task, so touch the red dot, then touch the blue dot, then touch the white dot, so multiple steps, but when you would add sort of language qualifiers in it. So touch the red dot, but only if there's no black square. Okay, so when you would add that complexity of language in there, that need to sort of keep track of, well, I'm supposed to touch the red dot and then hold it in mind while you figure out what to do with the second part of it, and to organize that all, a breakdown of that skill. Okay. She was on medication for her ADHD. We tested her attention, and she still had a tremendously difficult time passing our attentional task, and her profile was very much an inhibitory control problem. So the way this task works is it's a black screen, you get some flashy letters at you, and you're supposed to hit for a specific cue, but only if right before it another cue popped up. Okay? And what she couldn't do is the sort of the queuing in cue would pop up, and she'd hit immediately for that rather than waiting for the next letter to pop up. Okay, so she couldn't sort of inhibit, and she had to immediately respond. Okay, so again, an organizational thing. Visual and verbal organization, I've kind of hit on that already. Working memory and sequencing, I talked about that in the last slide. The other thing that was happening is that within her language, we were seeing this decline in her processing speeds. So if you gave her a sheet of letters and she had to identify A, B, C, and read them out loud, that process was, relative to her peers, much, much slower. So you can imagine, if you think of that then downriver, if you will, if I'm having much more difficulty just establishing what the letter A is and then building it with A and D, and that's the word and then I've got to put it in the context of the sentence, and I have to remember what I've read. Comprehension just was a complete mess by the time she got to try to read passages. And it started with just basic letter identification. Okay? Verbal fluency, and I talked about that earlier. So when you would ask her, tell me as many words as you could think of that begin with the letter R. Okay, that ability to sort of organize that in her brain, come up with the words, and come out with them fluently, very difficult for her to do. And if I remember this case correctly, for an average kid of her age, you would expect maybe 10 to 12 words in a minute, and she was getting like 3. And that was with sort of looking around the room and looking at posters and trying to use other things to kind of cue her brain into what she was supposed to be saying. And then the last one was mood problems. And so, like I said, psychologist first, we screened for mood and anxiety. She's very, very high on the anxiety and depression. And that's an important one because, and I'll take a step back here, these things don't work in isolation of one another, right? Mood affects cognition, cognition affects mood, home situation, home environment affects everything. They're all intertwined. And when you just met this girl, she just seemed incredibly depressed. And the more and more I got to talking to her, the more and more things came out, like I don't feel the same as my peers, I can't relate to them, they're all off looking for boyfriends, and I'm worried about when I'm going to have my next seizure, and they're all talking about getting their driver's licenses and moving on to high school, and I'm never going to drive. There's just this sort of hopelessness that was starting to emerge in her, and then, just talking at 12 years old about never leaving home and having to live with her parents forever, and that sort of stuff. And so the mood really kind of started to come out as being incredibly important, and again, even overshadowing some of the number deficits they were seeing. Okay, so basically with her case, we were able to, since she had an IEP, we were able to sit down with the school and talk about what we were seeing and where the shifts in the cognitive abilities were, how we could change the IEP to start targeting some of these skills, to bolster them, to give her some accommodation, to kind of help her out. They did a lot of stuff with helping her with structure. They did a lot of things like cutting down on lengths of assignments, so going to quality over quantity type stuff. It provided updated information for her medical team, and that was important because this case was a pre-surgical candidate, so they were looking to see, how seizures were actually affecting her. It gave it, in the feedback, it was a good kind of a therapeutic moment for Jane and her parents to be not only told that, yes, you're not crazy for thinking that these skills are dropping off or that they're not where they should be. We actually are seeing them. But then here's some of the reasons why we think we're seeing them, and here's what we're going to do to try to help them. And then it was an entree for me to start a dialogue with her about getting her into some individual therapy, getting her in to see somebody who did some specialized talk therapy work with children who have major medical illnesses, to talk about what it's like to be different and to feel different and to not be able to relate to your peers. And it ended up being fairly successful. From the last I heard, they've made some really good strides in the way that they've changed her academic curriculum to make things a little bit easier for her. And the bottom line was that neuropsychology was a good thing. Okay, so that's the end of my presentation. I will answer any questions you have.
What age do you typically see kids? How young do you see kids?
Yeah, so we will see kids, we have, at Dartmouth anyways, we have a 0 to 5 clinic that we will see kids that young. To me, it depends on what the question is that's being answered or being asked. I think from what the literature says, that intelligence in general doesn't crystallize and doesn't stabilize until about 6 years of age. So the variability that you get in performance, even a normal developing 6-year-old is only going to have so much of an attention span, and so from one day to the next, the scores that you're going to get can be dramatically different. So I personally don't like to put a lot of stock in the things that I'm saying until about 6, but we do see kids younger than that, depending on what the question is. So, yeah.
I have a couple of questions. One, do you think the neuropsych eval should be repeated every 3 years? So the school goes on a cycle of a 3-year eligibility, and should that be a neuropsych each time versus?
So my answer to that would be, if there's no reason to suspect that there's been a change, then I don't think it's always necessary to have a repeat neuropsych. These reports can follow for a long period of time. I would say that in the bare minimum around major transitions, it's worth doing. So more and more, for example, colleges are getting into the accommodation game and providing students with accommodations in school, and they require usually fairly recent testing to do that. So maybe from the transition to high school to college would be one period where I would say it's worthwhile doing. The transition from middle school to high school might be another point where it's worthwhile doing. Or, from when they transfer from like in 5th grade where they're in one single classroom most of the day to multiple classrooms, because that becomes, school at that point becomes a lot more about organizational skills, and if those are really bad, it's important to intervene at that point. But yeah, if there's no reason to suspect there's been a change and nothing's happened medically, for example, they haven't done surgery or they haven't dramatically changed medications, then it may not necessarily be something you have to do.
And is that a common trend you see, like for that case study you showed with, and would that be worth the monitoring piece of, from age 9 to 12 you saw some changes there?
Yeah, that does happen. I couldn't give you a percentage of how often it happens, but yeah, certainly we do see a number of cases where we will follow them 5 or 6 times by the time that they transition to adulthood, and then beyond that, I don't know what happens once they go to the adult side, because then they go to other people and I don't follow them. But it's not atypical, let's put it that way.
And do you ever break up an eval into 2 days? Because most of our kids fatigue.
Sure. That's a tough one. That's an incredibly tough one. So I can tell you what happens at Dartmouth. We have like an 8-month waiting list right now, so it's just impossible for us to break up evaluations. I would suspect that if it got brought up and we had a particularly forceful parent, that we might be able to work something out. But that's not the typical. That's not the typical way that we do it, and we just because of the time issue. If you were to have one done in private practice, I would assume that they would be able to accommodate that and split it up over multiple days. Yeah. Any questions? Well, thank you very much for having me.